Hello, thank you for joining the ERJ Podcast. My name is Dr. Don Sin. I'm the Deputy Chief Editor of the ERJ. Today, I'm joined by Professor John Fahy to discuss his paper entitled The Pathobiology and Treatment of Mucus Plugs in Both Asthma and COPD, a State-of-the-Art Review. Dr. Fahy is a professor of medicine in the Division of Pulmonary and Critical Care Medicine and the Department of Medicine at University of California, San Francisco. John, many thanks for joining us today.
Thanks for having me.
What is the clinical relevance of mucus plugs in COPD or asthmatic airways?
So I think the answer to that question has been informed by recent data coming from CT scans of the lung, which have shown that mucus plugs are prevalent in the airways of patients with asthma and COPD. And the relevance is that these plugs tend to occur in patients with more severe disease. They essentially are an imaging feature that occurs in patients with airflow obstruction. And one of the interesting things about the imaging findings is that these findings often occur in the absence of cough and sputum symptoms. So I think the reason for a state-of-the-art review at the current time has been since the first publication on the use of imaging to quantify mucus plugs in asthma in 2018, there's been, honestly, an explosion of papers that have looked at the relationship between quantitative assessments of plugging and clinical traits. And they all show that the plug counts, or the mucus plug segment score, associates well with measures of disease morbidity, not just airflow obstruction, but also exacerbations, control indices, even measures of hypoxia in patients with COPD. And I think the clinical relevance has been that it has illustrated to us that there may be a pathology here that's treatable that's been a little bit underestimated in the past or underappreciated.
What are the main mechanisms by which these mucus plugs formulate within the airways?
The short answer to that is that we don't really know. One of the things that as pulmonologists we had sort of led ourselves to believe is that mucus tends to occur in response to airway infections, exposure to airway pollutants, and that these mucus responses are transient, and that the mucus that forms is cleared over time and that the airway resumes patency. What's been surprising about these plugs on imaging is that we can see them persist over several years. In fact, in the first paper we had one, we could see 9 years later in the same airway. So I think what I've begun to think about is that we have mobile mucus in the airway and we have immobile mucus plugs. And I think your question may refer more to these immobile mucus plugs. And I say immobile, A, because they seem to persist, and B, they don't seem to be causing cough and coming up easily with expectoration. And so why would plugs occur and persist in the airways? And in the piece in the journal, I mentioned that my own thinking about this has been informed by cardiovascular medicine and the formation of blood clots, which can persist in some patients. And so you have these critical luminal lesions. I've even allowed myself to think about lumens that get occluded in other contexts, even like kidney stones or gallstones. So why do lumens get obstructed and stay obstructed? In cardiovascular medicine, we have atherosclerosis, which provides a sort of a risk, and then you get an acute event with an acute clot formation. Sometimes those clots are turned over and sometimes they're not. So I have wondered, and I wonder aloud in the piece, about whether these mucus plugs form initially during exacerbations when you have an acute, fairly significant inflammatory event, and that a subset of those plugs then maybe don't get completely resolved, and you're left with the residuum from the exacerbation, that residuum being that you have an occluded airway with the plug. And what's been surprising is that those plugs can persist for so long, because again, I think as clinical pulmonologists, we think the airways are pretty good at coughing up or finding ways to get those plugs out. But I think what we're recognizing now is that that's not necessarily the case, and that maybe some of these plugs form acutely, don't get resolved, and the airway mechanisms for mucus clearance fail chronically. and maybe a niche is formed where there's a sort of a crosstalk occurs between the elements of the plug and the elements of the airway wall. I talk in the piece about how there's a little bit of similarity there to thinking about niches that form for tumor persistence over time. Some of this is speculative, but I think it's good that the field is beginning to think about this question, because from that question comes rational treatment strategies.
That's so interesting. Perhaps we can just take a step back and just to clarify what constituents exist in these mucus plugs, especially the motile mucus plugs.
So in terms of these immobile plugs that seem to sort of persist in the airways, we did a study that was published last year in JCI. Maud Lijois, now in Belgium, was the first author on that paper, and we had significant help from Tilly Hackett at UBC, your own home institution, Don. So we used imaging mass cytometry to answer your question. What are the cellular and protein constituents of these plugs? So they definitely have a mucin glycoprotein scaffold. It's very difficult to create an immobile clot-like lesion without some sort of polymer. So in blood clots, it's the fibrin polymer, and in mucus plugs, you can't really have just a clot of cells. That's actually a tumor, and it tends to be vascularized. And so I think these plugs have to have a scaffold of mucin polymers, and the mucins involved here are MUC5AC and MUC5B. Now, one difference we noticed in the study we did with Maud and Tilly, where we looked at the Jim Hogg repository biospecimens to look at plugs in patients from asthma and COPD, we found that we could distinguish two kinds of plugs, sort of acutely forming plugs and chronic plugs. The acutely forming plugs tend to be protein rich, suggesting a sort of an acute mucus cell degranulation event. Goblet cells, probably the most important one there, maybe submucosal gland cells. So those acute plugs tend to be protein rich, but the plugs that persist over time tend to have a lot of granulocytes in them. And these granulocytes are a mix of eosinophils and neutrophils. We think that some sort of détente has formed in these chronic plugs, where normally the granulocytes bring proteases like neutrophil elastase that normally turn over the plug. But maybe in the context of these chronic plugs, there's a sort of a, as I say, a détente, and there's a sort of a niche forming that's mutually beneficent to all the constituents of the plug. In that regard, Rick Boucher published a paper in Science Translation Medicine some years ago, pointing out the role of hypoxia as a stimulus that can be important in these plugs. So when the plug occludes the airway, it'll decrease the oxygen content of that area of the airway, and that will send a stimulus to the epithelial cell. That's why MUC5B might be more prevalent as a mucin constituent of chronic plugs versus MUC5AC as a constituent of acute plugs. So you have hypoxia, you have crosstalk between the granulocytes and the mucins and the granulocytes, and then each talking to the epithelial cell. And again, some of my thinking here was, if we think about chronic clotting of the pulmonary vascular system that can give rise to pulmonary hypertension, some of those clots form acutely, don't get scrubbed, and become infiltrated with granulocytes over time. So I keep going back to these other kind of luminal obstructions because I think there's lessons to be learned. I'm not sure that the airways have dreamed up their own specific way for forming chronic occlusive lesions. But for the field, I think what's important is that I think they represent a form of respiratory failure. You know, you and I are used to thinking of respiratory failure as a failure of oxygenation or ability to get rid of carbon dioxide. But the lung is meant to clear mucus, because its airways are meant to be patent so that it can transmit gas to the gas exchanging region. So I think a failure of mucus clearance can be a chronic phenomenon in these diseases. And so you have these patients with asthma and COPD who have high mucus plug segment scores, low lung function, and that I think is important for the field. And I think that's to go right back to your what is the clinical relevance. I think the field has identified an imaging trait, mucus plugging, that is not unlike chronic vascular plugging or clotting that I think we have to pay attention to. And the good news is that where there had been therapeutic pessimism for some of these patients with airflow obstruction that was severe in both asthma and COPD contexts, because we didn't really have confidence we could reverse that, I think a focus on plugs gives the field promise that, oh, this is maybe a treatable trait. This is maybe something that can be reversed, and reversed maybe in our lifetime, as distinct from having to wait for a lot of advances in understanding fibrotic lung disease or vascular disease, which is clinicians were all very aware are tough nuts to crack.
Well, on that note, what are the current therapies, if there are any, that can treat the mucus plugs? And what are some of the promising therapeutics in the pipeline to treat or even reverse mucus plugging in either COPD or asthma?
The conventional wisdom about mucus had been that it's downstream of inflammation, and that inflammation begets mucus plugging because it drives goblet cell metaplasia, hyperplasia, drives secretagogue production from various cells, secretagogues being chemicals that upregulate mucin production, right? So the field had been thinking that inflammation gives rise to mucin hypersecretion. And so there's this emphasis on hypersecretion. And if you treat the inflammation, the mucus will go away. It's clear now that that's not the case, because these imaging studies from the big longitudinal cohort studies, SARP, COPD gene, spiromics, all of these patients that are having these images that are showing mucus plugs are on high amounts of inhaled steroids or whatever the conventional therapies are, inhaled bronchodilators, etc. I mean, it's possible that those plugs would be even worse if they weren't on those treatments, but for sure, the reliance on bronchodilators, be it muscarinic antagonists, beta-adrenergic agonists, inhaled corticosteroids, oral corticosteroids, that is not sufficient to tune down the inflammation enough to decrease the mucus plugging. If indeed the hypothesis is correct that the mucus plugging is downstream directly from inflammation. And in fact, you could draw a little bit of an arrow going both directions, and we could talk about that. So I wouldn't say that current treatments are completely ineffective, but they're obviously not completely effective. And so we need to think about perhaps better anti-inflammatory therapies, more specific anti-inflammatory therapies, or specific mucoactive therapies. The better anti-inflammatory therapies, our fields now are becoming aware of what these are. These are typically the biologics, the IL-4 receptor alpha inhibitors, the IL-5 inhibitors, and now obviously the alarmin inhibitors. And there has been data in recent years looking at mucus plug segment scores before and after these biologics. And I review that in the piece. And for people interested in that, there's other reviews coming out as well and have been published sort of documenting which drugs seem to be having an effect. The most robust data, I would say so far, and it's just because it's a little bit ahead of the others in terms of placebo-controlled trials, has been for dupilumab in asthma, showing that compared to placebo, dupilumab decreases mucus plug scores by about half. But there are still patients who have residual mucus plugs even with that treatment. Now, it's possible if you treat for longer, they'll completely melt away. But it's also possible that there's heterogeneity within these plugs and their locations in the airway, and some will be amenable to treatments and some will not. My own theory about it is that, and I mentioned this in the piece, is that we're going to have a multi-dimensional approach to treating mucus plugs, much as there's a sort of a multifaceted approach to treating clots. So if we think about blood clots in the vasculature, you have various strategies, including interventional angiography, you've got integrin inhibitors, you've got anticoagulants, and they're kind of given together and in sequence to sort of not just get rid of the plug, but then to prevent the plug from reforming. And we shouldn't forget too that within the mucoactive treatment paradigm, there's also cough assist devices and vests and things like that. But I would say that there's a relative dearth of specific mucoactive drugs like the dupilumabs and the anti-IL-5s and the anti-IL-33s of this world are still relying on the inflammation, treat that and you will treat the plugs. There's relatively few specific mucoactive drugs, specific ones that target the clot, like a thrombolytic. And so as somebody who's practiced medicine for about 40 years, I was around in the 80s when we saw streptokinase come in for treating blood clots. And I was very influenced that as a young senior house officer back in Ireland. I would see patients come in with ST elevation MIs in the emergency room, and we would give intravenous streptokinase and watch that ST elevation go down in real time. And we knew we were protecting heart muscle. So I just was very influenced by that. And I liked the idea that at some point, pulmonologists, respiratory physicians would have a drug that breaks up mucus and could do it maybe in a timescale of hours or days. And then maybe these anti-inflammatories would come in to be preventing the plug reforming. So I think we still have a ways to go to understanding why the mucus plugs have a high elastic modulus, which is what we find when we look at their biophysical properties. Some of that relates to cross-linking of mucins. Some of that relates to dehydration of the mucus. Some of it relates to hypersecretion of mucin polymers. So there's a variety of rational strategies for breaking up the plug, including drugs that target disulfide bonds, the thiol-based drugs that maybe hydrate the mucus in a way that might restore its ability to be moved by the mucociliary escalator. So some of those trials are ongoing. I mean, I've disclosed in the piece that I founded a company to look at an inhaled thiol-based drug based on a sugar scaffold, and we've published about that. Others are taking other approaches, and I think it's just an exciting time. In terms of overall strategy, I think some of these treatments are going to have to be given by the inhaled route, because I think in order to get a high enough drug concentration in the plug itself, you're going to have to give the drug by the inhaled route in order to get that concentration in the plug. It's similar to what you have to do for blood clots. You kind of can't dissolve a blood clot by popping a pill. You have to give someone an intravenous thrombolytic. That's where the imaging becomes helpful, I think, because the imaging can now show where the plugs are and what their length is and what their diameter is. And so a lot of intelligence can be generated in a before-after image. When you treat somebody with a drug, you can see where the drug is succeeding and where it's failing. You might be able to see regions of the lung. For example, the upper lobes may be a little recalcitrant to inhaled therapies because inhaled drugs don't get to the upper lobes as much. In that regard, it's sort of helpful that most of the plugs you see on CT scanning are in the lower lobes, which should be a very druggable region of the lung. And the plugs tend to occur in airways that are generation 6 to 9, which again should be very druggable.
Absolutely right. And I think with the advent of photo counting CT and hyperpolarized xenon gas imaging and others, I think you have a very good combination of novel therapeutics and imaging methods to assess the therapeutic efficacy, perhaps even in real time. So this is a very exciting and a very promising field of research. So thank you to Dr. Fahy and for all of you for joining us today. Professor Fahy's full paper is now available on the ERJ website.